everyone. I'm John Lynn, the founder and chief editor at Healthcare IT Today. We're excited to bring you another in our series of interviews with top leaders in healthcare IT. And today we have a really fantastic duo to talk about prior authorizations. We have Tina Cummings. She's VP of Clinical Operations and Performance at GuideWell Health. And also Dr. Jeremy Friese, President of Payer Market at Olive. Welcome, Tina and Jeremy.
Thank you for having us, John.
Yeah, well, Jeremy
Thanks, John. Great to be here.
Doing it remotely, so this is going to be a lot of fun. This new remote world, we have to do where we are, right? So before we dive into prior auth, Tina, you want to tell us a little bit about yourself and GuideWell Health?
Sure. So I have been at GuideWell for going on 24 years, and I lead our clinical operations area that has responsibility for our utilization management. And so GuideWell, our vision is to be an innovator in healthcare, in the healthcare space, and to live our mission, which is to help people and communities achieve better health.
Awesome. Great to have you here, Tina. And Jeremy, tell us about yourself and Olive.
Greetings from a road between Jacksonville and Orlando. Really wonderful to be here with you, John and Tina. I'm a physician by training and have the great pleasure of running our payer business here at Olive, where we are on a mission to transform the business of healthcare and automate the back office work that so many humans do today on both providers and payers, and have the great pleasure of running our payer business, John.
Awesome. Great to have you here. Well, Tina, why don't you start us off? Why haven't payers automated prior authorizations previously? It seems like everyone wants that, but why hasn't it happened? You're on mute.
Sorry about that. I would definitely say that it's probably because the technology just hasn't been there. Certainly for us at GuideWell, over the years, we have made some improvements.
Sure.
We have created algorithms. We've done some auto approvals over the years. We've also done some clinical forms, attestations. So along the way, we've tweaked it. We've improved what we could, but I think that the technology just hasn't really been there until lately. And so for us, we've sort of evolved as the technology has evolved. And so now that the technology is here, we're ready to make that leap.
Yeah. Well, we'll talk about your pilot in a second. Jeremy, anything you'd add? Obviously, you talk to a lot of payers with your work.
Yeah, I couldn't agree with Tina more. The fact of the matter is prior authorizations have pretty much been done the same way for decades for the most part. It's a process predominantly done with manila folders and Post-it notes and humans. And and fax machines, frankly, and the technology just hasn't been there in the healthcare space to do this, and that's what we're excited to work with Tina on and bring this to scale throughout the state of Florida.
Yeah. So, Jeremy, what does it really take to automate it? Right. Obviously, it's a massive shift from vanilla envelopes and faxes to actually pure automation. But what really goes into automating it?
So. It's really hard. And the reason it's been so difficult to do is because it takes human knowledge to understand the medical policies that Tina's team reviews and match that up with the clinical documents that a hospital or physician group will send over to Tina's team. And so what we've been able to do together is to build the technology that maps those clinical rules to those medical documents that a human would usually read and understand. And so in the past, the most automation that Tina talked about are these decision trees, where I, as a physician, would have to go through these decisions and say, yes, Mrs. Jones, has knee pain, no, she doesn't, whatever. And so the level of automation is very, very different in the market than what Tina and team and Olive are excited to bring to bear.
Yeah, it's interesting. Anything you'd add, Tina, as far as it seems like such a complicated thing, right? Because prior authorizations are more about exceptions than there are rules, and automation loves rules.
You would think. And I think that automation does love rules, but automation doesn't like complexity. And I think that's what is so different about the rules that we've created. So in healthcare, they are not black and white. There's a lot of variation. And so, so for example, when you go to have let's say an MRI of your head, you could be going to have an MRI because you have a headache. You could be going because you have pain. You could be going because you have vision problems. So the diagnosis for why you're actually going to have that test could be a whole series of variations of why you're actually going. And so each of those different variations now has a different set of questions as to why that test is necessary, and is that the appropriate course of treatment. And so because of all those variations, the questions that we would ask for the medical necessity of whether or not that is the best course of treatment, is it the right, the most effective treatment plan that should be happening, those are the questions that are inside these medical coverage guidelines that Jeremy's talking about, that have to be read and then interpreted and then matched up against your medical records. And so that's what makes it so complex, because you're right. Automation loves rules. If you can make a rule, then we can automate it. The problem is it's the variation within those rules.
And I think doctors that would be
And
listening to this, sorry, Jeremy, one real quick, like doctors listening to this probably hear it and say, well, can't you just trust me? Right. Like, yeah. What do you say to them?
Absolutely. Well, and I think that that's probably the very first question that we always get. Why, right? Why do we have to do prior auth? And really the overarching benefit is to ensure safety and to optimize the patient outcomes, as well as reduce costs, for the patient as well as the healthcare system overall. Unfortunately, there's a lot of overutilization in the system today. And so all of that overutilization is really expensive and costly, and it's costly to everyone. And so unfortunately, when people have services that are unnecessary, that cost unfortunately turns right around and ends up in their premium. And those are the things that we're trying to control. And for us, we want to make sure that the efficacy of those things that are happening to our members are appropriate. And so again, we're really doing it for the protection of our members. And again, if we didn't deny things, then we'd stop doing it, right?
If you had zero denials, there would be
that's
no
right. That's
issue
right.
with prior auth. That's interesting.
Yep.
Jeremy, what were you going to add? Sorry, I cut you off.
no, that's good. I'll jump on this theme. I mean, I'll be the first to admit, as a physician, there's extraordinary data that shows there's extreme variation in the delivery of healthcare across the state, across the country, and the Dartmouth data shows this very clearly. And so it truly is, prior authorization exists for a reason. Not, most physicians and maybe some think it's just to control costs, and that's certainly a component of it, but it's also to ensure that this variability, when appropriate, can still happen, and that's why there are checks and balances in place. But to sort of make sure that the right care is getting delivered to the right patients, based on their individual circumstance. And that's another reason why being able, Tina's nurses have such a difficult job of understanding the medical documentation that a physician or mid-level provider has documented, matching it up with these medical necessity rules. That's not a black and white thing, and why this is such a dramatic leap forward from a technology standpoint to be able to do that as we're now doing in Florida.
Yeah. So let's talk about that pilot in Florida. Tina, maybe you could outline what was the pilot and, how did that go? How far did you implement? It sounds like there was a lot of automation, but describe what happened in the pilot.
Sure. So what we did was we worked with a large orthopedic practice in Florida. And so what we did was we tested Olive, obviously, on a smaller scale. So we needed to understand and test the logistics of what we were putting in place before we spent more resources pursuing this solution, right?
Sure.
And so what we did was we embedded the solution into the orthopedic practice. And so the orthopedic practice, when a physician ordered a test that would require a prior authorization, the front office would make the request for an authorization. And when they did, the software would then pull up the request. It would then say, okay, what's the coverage guideline? And then it would go and get the medical records that were in the system, in the EMR, the electronic medical records. And it would say, okay, this particular, let's say, coverage guideline says it, let's say an MRI, they need to have conservative therapy and maybe a flat x-ray before they have this procedure. And so it would say, hey, does Tina has she had PT for 6 weeks? And has she had a flat x-ray? Yep, there it is in her records. It matches up. It tells the person who's requesting the authorization with the payer, which is us, check on those 2 boxes, and they go ahead and submit it, and then we auto-approved it. And it says that Olive is making a recommendation that they've met all the criteria, and you can go ahead and approve it, GuideWell. And then they submit the authorization request, and it auto-approves. And we were like, this is fantastic.
The provider probably liked it too.
Oh, they loved it. They loved it. They were like, you are never going to take this away from us. And so for us, we saw 56% of the requests had an immediate decision sent back to the provider. Wow. And so they were elated. And also we saw a 27% decrease in requests that were being made to us where no authorization was actually required. Because a lot of times what happens is a provider doesn't know if something requires an authorization. And so they are worried about the revenue, right? They don't want to do procedures that will then obviously cost them money. And so they go ahead and make requests for services that actually don't require authorizations. And so now they have their patients are waiting for services that don't require authorizations, and they don't need to be waiting, right? And so again, we saw a huge increase in the automation of auto approvals, and we saw a decrease where people don't need to be waiting for things that don't require it. So it was a win-win. And we ran the pilot for almost 15 months because we were in the middle of COVID. Who knew there'd be a pandemic, right?
Yeah. So were they able to do all the prior authorizations, or was there a subset that you did, or how did you approach that?
So because it was an orthopedic practice, we had written we chose the guidelines for around hip and knees. So we have an authorization program. If someone needs to have a hip replacement or a knee replacement, we have a UN program that's specific to that. And so we request authorizations for those 2 types of procedures. And so it was right in the wheelhouse for this particular orthopedic group, because that's what they focused on. So that's really why we approached them. And they were obviously very excited about being selected. They were a very large orthopedic group. And so that's what they do day in and day out. And so we will continue to move forward with that program and then additional programs as well.
Gotcha. Jeremy, anything you'd add to this? And I mean, to me, it's fascinating to hear how embedded in the provider organization you have to be able to do this. I mean, did you get access to the EHR, or how did you approach that kind of embedded workflow within the practice?
Yeah, you highlighted an important point there, John. We're on a mission to remove friction from prior authorization for providers and payers. And there, just as Tina was highlighting, it's a lot of work and manual labor on both sides. And so this particular orthopedics practice that Tina was speaking about was already an Olive customer on the provider side. So yes, connected into the EMR, we were helping them submit their prior auth to Florida Blue, but all of their payers. And then to add this extra ability to do automatic approvals was a real game changer for them. And so what Tina and team and Olive are doing as we roll this out at scale across Florida is not just for the providers that have Olive on the provider side, but really able to do this automation and decision making strictly from the payer side, which is pretty exciting.
Yeah. So what is the rollout plan going forward? And I don't know if Tina, you want to start, like you started with this one practice, obviously, ortho's a big practice, a lot of revenue. We all know that in healthcare. Is it to roll it out to the rest of the ortho, or are you looking at other specialties? What's the rollout plan going forward?
So we intend to roll out hip and knee to all of our providers effective April of this year.
Okay.
And then in the summer, we will roll out 2 additional programs for 2 different specialties. And then we will also, in Q4, we will add a 4th program for this year. So that's what our roadmap looks like for 2022.
Gotcha. Anything you'd add, Jeremy, on, this sounds like how is it going to work if they don't have Olive? I think that's a fascinating rollout that's a bit challenging.
So with Olive, we have the ability to, in the state of Florida, we use an all-payer system, which is Availity. And so all of our payers use Availity, and that's how they submit through the gateway. So that is our front end on all of our transactions. So if our providers want to check eligibility and benefits, if they want to check claim status, if they want to submit an authorization, they're doing all of those transactions through that portal. And so what we're able to do is we're able to provide them the ability to do that through that portal, through something that they already use today, which is another big win for us in the provider community, because we have a huge adoption since that's something that's been in place for almost 20 years now in the state of Florida.
Right. Jeremy, how would you kind of look at this? We won't force Tina to say big picture, where are they going with prior auth, but where do you see all of this prior auth automation going?
Well, I think it's a really interesting question, both from a governmental perspective. As many of your listeners probably know, there's a push across the country on what to do, both for government payers, but also, for commercial payers. As Tina and I have been saying, utilization management, prior authorization is here to stay. And we view it as our job to really help make sure that this happens in a friction-free way, as little effort as possible for both sides, but still maintain the positive aspects of What we see happening is, and see, strong adoption across the country, and just to continue to expand it across specialties. We see that initially at scale here with Tina, we'll have about 60% of the authorizations that we'll be able to do in an automatic fashion without requiring all this human intervention. And then frankly expect over time that we will get that up in the 80% range, recognizing that, as Tina said, there's a lot of gray zone, and some things will just frankly always require a human to do and should require a human to do. And so that's the march that we're on, to expand specialties. And Tina talked about, we're adding a few more this year, and just to continue to do that over time as our databases get stronger, so that we can understand that medical language across specialties and roll out the automation, broadly across specialties.
Yeah. Great, Jeremy. Thanks so much. I appreciate you guys sharing this insight. I jokingly said prior auth is a super simple problem that is easy to solve at the beginning, but I think we all know that was a joke. It's one of the most complicated things and most complex thing. I mean, healthcare in general is complex, and prior auth is just another order of magnitude more complex. So thanks for sharing some insight and perspective, and great to see some automation actually coming to prior auth. I think every healthcare provider out there would welcome this type of automation. So thanks so much. And thanks everyone for watching. If you want to find more great content like this, be sure to check it out at healthcareittoday.com, or search for Healthcare IT Today on your favorite podcasting application. Thanks so much, Jeremy and Tina.
Thank you.
Thanks, John. Thanks, Tina.